So this is not a gender-specific talk. This is sort of looking at where we're going or where we may have a chance to go. My task is to talk about the orthopedic applications of stem cells. So really, stem cells, this concept of regenerative medicine, we know about this. This has been used for the last 50 years in bone marrow transplant. We can study new medications with stem cells, and we can deliver cell therapy to the spinal cord, to Parkinson's, to Alzheimer's, to heart disease and stroke and diabetes. And these are all exciting applications that we read about in research institutions that are working here. But orthopedically, how can we harness this regenerative medicine, these cells that can potentially help and regenerate ourselves orthopedically? Well, we can look at bone fractures and non-unions and ways to fuse bone. We can look at articular cartilage, the gliding cartilage in our knee. Can we help to regenerate or restore our articular cartilage? Can we slow or mitigate the processes of arthritis? Can we look at ligaments and tendons? Really, I mean, this is Sports Medicine 2017. Faster, better, stronger, and less invasive. And this is where we're hoping, and I'm hoping, that stem cells are going to take us. So what are stem cells? Let's take a step backwards from the moment we're conceived. We're a unicellular organism. And that organism, that embryo, will divide into cells. And after 3 to 5 days, some of these cellular divisions are going to get specific specialization orders. Some of your cells are going to get turned into bone cells. Some of your cells are going to turn into kidneys. Some of your cells are going to turn into brain cells. And once we go through this process, the word is differentiation. Once these cells differentiate, they really can't go backwards. Given marching orders, they don't go backwards. However, and here's an example of what a stem cell can do. A single cell can turn into nervous system, to heart, to vessels, to kidney. So you imagine one cell in our body has to figure out how to become this miraculous organism, and it does, and it figures it out. But a few get left back. And unlike in high school, when the people who get left back have maybe less potential, these cells that get left back have the most potential. Our body has some capacity to regenerate and repair tissues when injured. Not an entire capacity. We can't fix every tissue that goes wrong, but believe it or not, we can fix some of them. And our existing stem cells currently in our body, they help replenish our kidney cells, our liver cells, our bone cells, or even our heart cells. So by definition, if we're going to take away some sort of strict definition of how we define what a stem cell is, they're an unspecialized cell capable of renewing themselves through cell division even after long periods of activity. So you could have this stem cell there for 15 or 20 or 40 or 60 years in your body. And under certain conditions, we can induce or we can trick these cells into becoming tissue or organ-specific cells with special functions. We can take this stem cell and tell it to become ligament, tendon, or bone. And orthopedically, now going back to it, we can look at putting this into your stem cells into a fracture that's not healing, or to a spine or an ankle we want to fuse and have it to fuse faster. We can put it on your articular cartilage. We can put it on your ligaments and tendons. Well, where do they come from? Where do stem cells come from? And I think this is an important understanding and divide. There are embryonic stem cells. These are donated tissues. These are placental tissues. And these are cell lines. And these are very versatile tissue lines. And they can be programmed to become any cell. So, and this has received attention in the media and can be somewhat controversial at times. However, orthopedically, we're talking about the adult stem cells. Another word for adult stem cells is somatic stem cells. And this can come from your blood, it can come from your fat, or it can come from your bone marrow. And only in 2012, really, a year and a half ago, the Nobel Prize was awarded to 2 doctors who looked at adult stem cells and said, maybe we can even reprogram your adult stem cells into doing anything we want them to do. So, is this happening now? This is it. This is the Nobel Prize of 2012. We're going to talk specifically about adult or somatic mesenchymal stem cells, so MSCs. And these are the ones that will have the capacity to differentiate into bone, tendon, muscle, and cartilage. So they've already gotten some marching orders. They've already come down some specialization pathway, but they have not gone all the way down the road into exactly what their final function will be. And we can get these, as I said, from bone marrow, from adipose, and blood. And really, if we look at where the best concentration and where the best cells are from the bone marrow. So your adult stem cells. These are undifferentiated cells, and they are, I think I wrote the word pluripotent, but they're not quite pluripotent. I think they're more multipotent. And what is the differentiation there? Pluripotent means it can become any cell that I want it to be. Multipotent means it can become a lot of the cells that I want it to be. And the adult mesenchymal stem cells are much closer to being multipotent. And these are the primary issues or the primary cell for orthopedic and spine surgery. And the iliac wing, our hip bone, is where we get it from. So how do I do this? How do we get them? Can we do this now and today? And the answer is yes, actually a couple times last week and a couple times the week before. a needle, a trocar needle, is put into your pelvis through a percutaneous or a small little stab cell, and the blood is drawn out. And the blood has stem cells, has white blood cells, has red blood cells. And I'm going to show you this in a second, but this is it. This is how tricky or complex it is. So here in this video, you can see this is in the operating room. That's the needle. It's about a third the size of a pencil. A trocar goes into your bone. That's some anticoagulant liquid, and we pull the blood out. We change the direction of this needle a few different times, and the reason we change the direction a few different times is because we want to harvest from a few different areas. The stem cells don't just all hang out in one corner of the room. They disperse evenly. They're good social actors. And that's it. The stem cells are harvested. There's the tiny poke hole. A steri-strip goes over that, or a small bandage goes over that. It takes about 10 or 12 minutes. So this fascinating concept of where do they come from, or how do you do it, that's it right there. That's how you get them. We can do this in the office, although quite honestly, we're still doing it mostly in the operating room setting because it can be a little uncomfortable. Then what we'll do, just a little. Then what we'll do is we'll fractionate this, and people sort of have a tough time differentiating between what a stem cell is and what a platelet-rich plasma cell is. And the platelet-rich plasma cell, we're just going to spin the blood down and take out a centrifuged layer of cell to isolate our platelets. In the stem cells, we're actually looking. The machine looks quite similar, but it's doing a whole lot different. So now these stem cells, or this iliac wing aspirate, is injected into this machine, and this machine is not just a centrifuge. It's actually a flow cytometry machine. So using a combination of centrifuging, but then like when you go to the grocery store, each item has a barcode on it. Interestingly, our cells all have barcodes on them. And this device, this flow cytometry device, can send the cells through the scanner and then identify where these exact stem cells are. And then really, I guess I want to skip to the end again. Once it goes through, once they're coded and scanned out, it will send it into separate red cells, separate white cells, separate platelet-poor plasma, and then really this concentration of our stem cells. And from about 100 cc's of aspirate, we'll get about 8 or 9 cc's of concentrated stem cells. And here at the very end, you'll see this is what it looks like. And we'll dilute it out just a little bit with some plasma. But that's the magic juice. Those are the stem cells. That's what we're looking for. And as we talked about, here are the different applications. Well, look, what does the research say on this? Are we there, or is this just still the Jetsons sci-fi? Well, here on the top, on the A column, is a mouse study, or a rat study actually. And what we're showing is bone broken, and then what happens? What does the normal body do when we leave a gap behind of bone? And you can see as you progress along the column from immediately post-op to 16 weeks, the body tries. It tries to get closer and closer, but it really, the osteocytes can't jump that far. This has exceeded their capacity to heal. But we inject stem cell into that defect, and look what happens. Right away you see bone forming, and at 16 weeks, the body has formed bone across that. So that's great. We can do that in the lab. But what happens? Well, the picture on the left, we've had a lot of our young Americans fighting combat now, and they come back with significant injuries and bone loss and bone defects. And we're looking at ways to make that better. And here you can see an example of an external fixator with a tibia with a lot of bone loss. These can go on to non-union. Looking at this now, we can inject these non-unions. We can inject these fractures with stem cells, and it works. It heals them up. So in a study from France, we looked at 60 patients who had non-union of the tibia, and without additional surgery. So the traditional event would be take iliac crest bone, take a bone marrow graft, put it into the fracture, replate the fracture, redo the fracture. 53 out of 60 of these non-unions went on to heal with injection alone in the human population. So, you know, stem cells are not coming. They're not going to be a good idea. They're here, they're now, they're working. And in fracture application, we are using them on a regular basis. Osteonecrosis is another rare condition. The blood supply to a joint can somehow get interrupted from a number of different reasons, whether it's trauma, whether it's the use of steroids or other medical conditions. In a study, in 2 different studies, one from Michael Mott in Boston, 50% of patients who had standard decompression surgery for osteonecrosis. So at the time of surgery, we open the joint up, we create some vascular channels by creating holes in the bone, and see if our body can then restore and regenerate this. 50% of patients with osteonecrosis who had decompression surgery went on to requiring joint replacement. When you did the same surgery with injection of stem cells, only 10% went on to requiring joint replacement. So once again, human studies that are happening now with a maybe 15-minute additional intervention to get your stem cells out. Arthritis and meniscus surgery. This is really exciting. Again, this is 2014. This is just released. In patients who had surgery to remove meniscus and had stem cells injected at the time of surgery, when we looked at them a year later under MRI, they had more regenerated meniscus, 24% more after a single injection of stem cells. Lisa Fortier, who is a veterinarian at Cornell, who looks specifically at horses and racehorses, looked at microfracture in horses. And when she would do a microfracture by adding stem cells, she had better integration, she had better cellular coverage, and the histology of the cartilage. So we are making more real cartilage. So these things are happening regularly and actively. And again, just sort of looking at specifics, we'll often see a young athlete or a 35 or a 40-year-old athlete who will have a small trauma, and on this larger picture on the right-hand side, you can see normal cartilage and a hole stuck in the middle of that. Well, that hole, we can either treat that with microfracture, and the idea of microfracture is to create small perforations so that our body can deliver stem cells to it, or we'll transplant cartilage in. You can see small dowels of cartilage transplanted in. Well, the future now is to take a disc of tissue. It's got some of your own cartilage cells. We'll dip that disc into your own mixture, your own puree of stem cells, and put that disc in. And that disc may actually be the answer to get you better, more real cartilage. Torn ACLs, Dr. Vidazzi talked about this, and we're not there yet, but the idea of putting in a fake ACL, a synthetic nylon ACL, dipping it in your own stem cells and trying to get that to incorporate, to get you back to sports at 3 months, to have no morbidity associated with a cadaver graft, which we really don't favor that much anymore, or no morbidity associated with your own graft, and return to sports back at close to maybe 2 or 3 months afterwards. Not such a life-changing, devastating event. We're not there yet. We're trying hard to get there with ACL, and we're working hard at it. And we've fallen down a few times, to be quite frank with you, but we're working hard towards it. What about arthritis? Our largest unmet need is this 35 to 40-year-old who's got arthritis. We don't want to put knee replacements in you if we don't have to at 35 and 36 and 40. Can we inject stem cells into you? And will this work for arthritis? The answer is, well, maybe. We're going to try. Adult stomatic stem cells, these mesenchymal cells, are exciting and they're new. And the iliac wing is our source. You saw how we get them. Our preliminary research is very exciting. And this is really, we're just touching on this. We're just cresting on how we're going to understand this and harness this. Pharmacological use of stem cells works well for us now. Gene delivery is working well in the labs. There's non-orthopedic applications, and the orthopedic application is where I'd like to go with this. That said, this is while I've been very excited and upbeat, this is still very tricky. And here's just a more complex slide showing you what that stem cell that starts up on the top of the slide actually has to do to get down to bone. So while I say we inject it in and we hope it's going to work, we still don't fully understand what these 6 or 7 different steps to get it from point A to the final point are. And understanding these processes and understanding how to regulate these processes is going to be an integral part of making this work for all of us in our future. There's currently no adverse reported events of this. This is your own tissue, so we're harvesting your own tissue, and we're really going to try and change this to regenerative medicine. There's a caveat to everything. Look, there's a risk for abuse of these cells, and the internet is marking this for a host of ailments. And what we don't want this to be is we don't want this to be snake oil. I think as surgeons we have to regulate in whom this is a reasonable and acceptable and ethical process. So in conclusion, this is it. Welcome to the future. I think that we're applying it today, tomorrow, and I'm excited about what we'll be doing in the next 10 years with this. Thank you.